This is the second webinar in our Insight series for 2021, presented by SafMed, hosted by SafMed, sponsored by SafMed. Thank you very much, SafMed, for sponsoring this session. SafMed is your solutions partner and has been so for the last 30 years and can assist you with a range of both capital equipment and consumable equipment for use at your CSSDs and your theatres. This is the second webinar in our Insight series for 2021. And as you can see, today we'll be focusing mostly on radiation safety and ergonomics in the operating room. Webinar 3 will be hosted on the 19th of May from 11:30 to 12:30. We'll be focusing more on CSSD topics, including brush selections, importance about how to use a brush correctly, brush techniques, and a very interesting discussion around droplet dispersal in the decontamination area. Webinar 4 will have a surgical focus, and that'll be on the 26th of May. All of these webinars are based on published papers, on webinars attended over the last year or so, giving us insights into 2021. This webinar and all webinars hosted by SafMed are really a result of a collaboration of the SafMed team. So thank you very much to everybody who's participated and assisted in the creation and management of these webinars. Today's session, webinar 2, we're going to begin with radiation safety. We'll talk a little bit about the Alara Principle. We'll talk about protecting the perioperative team from a radiation perspective. We'll focus on decontamination of our lead aprons or our protective garments as a whole. And lastly, we'll focus on ergonomic challenges in the operating room. As we all know, those of us working in the perioperative environment, our perioperative staff are often exposed to radiation, especially during orthopedics, urology, procedures where we're visualizing the biliary tree, cardiothoracic surgery, vascular surgery, but to name a few. The effect of radiation, of course, is directly related to the amount or the dose and the length of time of exposure to the radiation. That exposure is cumulative, and that can be problematic. Because of the extended latency, the effects are obviously not noticed, and they generally are only evident a number of years later. Of course, radiation can be used in therapeutic doses to prevent cancer and to visualize structures, which of course is what we use it for quite frequently. Excessive exposure can, of course, be really terrible and can cause cataracts, cancer, bone marrow injuries, burns, necrosis, genetic mutations, spontaneous abortions, and congenital, I want to keep saying abnormalities, anomalies. Lymphatic tissue, thyroid gland, and bone marrow of the sternum are especially sensitive to radiation. And that's why, as a result, we need to think carefully about our own safety in the perioperative environment when it comes to radiation. In the Association of Operating Room Nurses Journal, in the May edition, so this is hot off the press, there is an article that reviews the latest radiation guideline from the AORN. They recently updated their guidelines as a whole, and we'll talk a little bit more about some of the changes in webinar 4. But specifically focusing on the radiation safety webinar, we'll go through this article, which describes a lot of the guidelines, but not all of the guidelines. Remember, these guidelines can be purchased separately from the AORN. We don't have a copy of the latest guidelines, but thankfully they do discuss them in the journal publications every month, which we do have access to. This particular article is divided into a few sections. It talks firstly about the healthcare organization's roles and responsibilities. It talks about a radiation safety program, about how to manage patient exposure, about perioperative team exposure, how we look after ourselves, about perioperative team members who may be pregnant and how we need to manage that. And then it talks about monitors or measures or methods to monitor our exposure. And lastly, it goes on to discuss radionuclides and radiopharmaceuticals. So we're going to touch on each of these aspects and see what we can learn out of the AORN's guide. From a healthcare organization perspective, of course, the guideline says that we need a radiation safety program and we need to appoint a radiation safety officer. Remember, what I'm describing now of the guidelines is the article itself and the explanations from the US. There are slightly different variances and nuances to the South African guidelines, and we'll talk a little bit about that. We'll touch on it briefly, but perhaps these are things that we need to take into consideration when we're managing our own operating theatres. Should these be aspects that we should be incorporating, and do we incorporate these already? Do we have a radiation safety program? Do we have an appointed radiation safety officer? The radiation safety officer also has a responsibility to monitor the perioperative team's exposure to radiation. They have a responsibility to provide the radiation shielding devices or garments. They have a responsibility to retain all of the records, keep the records, know what they say. And they have a responsibility to provide education around principles of protection and radiation exposures. I personally have not really had any lectures around radiation safety that I'm aware of, so I think it might be something that we're lacking in. Some people may have had exposure to a little bit more education around it, but I do think it is something we need to think about. A very important aspect, it says over there, is that the healthcare organization may only allow qualified personnel to operate radiological devices. I'm not sure how things are at the moment or how it stands in your environment currently, but I know I scrubbed for urology for a number of years, and often only the surgeon himself was the one who operated the radiological device. And I'm not sure that he's the most qualified person to do that. Nanette has shared an experience before where a hospital, in fact, one operating theatre within a hospital had to be closed because a non-qualified person, who by the way was a surgeon, was the only person doing the screening in that hospital, in that theatre complex. And that theatre was then closed for a period of time by the DOH till such time as it was deemed to be compliant. What does a radiation safety program entail? So according to this article, it talks about having standard operating procedures, and those standard operating procedures must cover a variety of things about the use of radiation equipment, how the radiation equipment is stored, how the radiation protection garments are stored, and how you maintain the monitoring devices themselves, so the dosimeters, for example, that we use. There should be an SOP for handling and disposal of bodily fluids and tissues that may be radioactive. And of course, a list of approved equipment operators. This comes up frequently in this guideline. There should be a method for identifying and selecting new radiation equipment. So one would hope that those that are in the know, or those that are in the procurement departments, in your head offices, are fully aware of what it is they're buying. Hopefully they are looking at new technology, because of course there is newer technology that requires less radiation doses, and hopefully you're buying the equipment like that has some form of protective measures to it. Are they buying the correct standard of lead aprons? Or, of course, these days you get aprons no longer made of lead, but lead equivalent. And for example, if you are going to be closer than 1 meter, you're going to need a lead apron that has a thickness of 0.5 millimeters, I think it is. Do you have a quality assurance program in place for your radiation safety? So a very important aspect around radiation safety is not just what we do in the operating room, but it's those in the organization that have roles and responsibilities, and those in procurement that have roles and responsibilities, keeping us all safe at the end of the day. What about the patient? I don't know what you do in your operating rooms, but I don't recall in our urology theatre that we did too much to shield the patient. We exposed the patient to a huge amount of radiation, especially in the urology setting, in terms of my experience, but I don't recall ever using any protective devices on the patient themselves. Of course, we should be shielding the patient. And what areas do we shield? The thyroid, the ovaries, the breast, the testes, which is a bit difficult in urology, but certainly those are areas that need protection. There are debates about where you need to place the protective devices, and of course, if you are in a sterile field setting, where it is that you're placing the devices, that they're not getting in the way, or they're not slipping, or they're not falling, or they're not a contamination risk. From a patient exposure point of view, I think some of the perioperative documents these days do have a section where you're going to record the dose of radiation. And if it doesn't, where do we record that dose of radiation? Do we know what the dose is? Is the radiographer coming up from the radiology department to manage the equipment? And if so, are they recording the dose of radiation? Where's it being recorded? Are you recording the types of radiation as well as the location? And a very important aspect is, have you done a pre and post-op skin assessment? Because remember, we had just commented on the fact that radiation can cause burns. From a patient exposure point of view, also very important to know which side of the C-arm, which we often use in the operating room, is which. That big round section on the top, that's the image intensifier, and the X-ray tube is the other little section at the bottom. Always keep the patient as close as possible to the image intensifier. The operating room staff should also, where possible, stand on the side of the image intensifier. And of course, depending on the angle, if you're doing a lateral view like is in the picture below, you can't do this. But if you can, try and put the X-ray tube underneath the table to help decrease the radiation scatter in the operating room. What is the Alara Principle? So there is an extract of the diagram on the right. If you look at that, and there is a link to where we Google that information from. The Alara Principle refers to as low as reasonable achievable. So trying to get an image or visualize a structure or do whatever it is you need to do, but using the least amount of dose exposure to radiation as possible. Of course, by lowering the time exposure and by increasing the distance, at the end of the day, you'll decrease the amount of exposure or the amount of radiation exposure as a whole, both for the patient and, of course, the staff in the area. And the third aspect is shielding. So those three aspects all added together will help protect us. In the guideline, it's quite specific. It says remain at least 1.8 meters away when you can, of course. Limit the time spent close to the radiation source. Always alerting the team before activating the equipment. I should think everybody's really good with that. Wear your radiation protective garments. Always make sure you're covering from below the chin to the knee level. And that's very important when it comes to choosing the right size of gown or apron. And wear eye equipment if you're unable to distance yourself from the radiation source. The guidelines goes on to talk about various bits of radiation protection equipment. It refers mostly to radiation safety garments. There's not much clarity on all the types of garments, but of course the types of PPE does include aprons, thyroid shields, gloves, and I believe caps are also available now. You can use wall-mounted shields, you can use mobile shields, and of course you can put on the aprons. The image on the right of the aprons are the ones that I'm most familiar with. I'm not sure if they're similar to the ones you may be using in your departments. If you are using those type of gowns, remember, of course, that the back is not that well protected. So never stand with your back to the radiation. Gowns or aprons are now available in a lead-free option, which I understand are a lot lighter to wear and maybe a little bit kinder to us. But that again talks to the procurement department and the importance of having a device that's going to do the job correctly for you. Important, of course, is inspecting the protective shield devices, whatever it is, thyroid, shields, etc., for punctures or tears, and having them tested annually for effectiveness. And of course, documenting those results, not just testing, but making sure you actually document those results. The guideline says clean and disinfect the items. If it's worn by one individual, then you can disinfect and clean at the end of the day, in essence. But between uses, of course, you often change from one user to the other, or one wearer to the other, or the apron even goes from one theatre to the other. Please make sure you clean and disinfect between uses. And the guideline says follow the instructions of use from the supplier or the device manufacturer. So we went ahead and Googled some instructions for use, and this comes from a product available in the South African setting off their website directly. And on their instructions, it says, firstly, when in use or when not in use, your apron should be stored properly or correctly on an X-ray hanger or a wall-mounted rack. It says remove stains immediately when they occur. It says if this is not possible, clean with warm water and a non-bleach cleaning solution. And they recommend a particular cleaning solution that they have available. It says don't submerge your aprons in water. Don't fold the apron. Don't drape the apron over any furniture or equipment that's not designated for apron storage, obviously because this could damage the core of the apron. Don't lean against pointed objects or sharp edges, which is a very valid point, while you're wearing your apron. And don't expose your apron to extreme temperatures. Going back to the guideline review, the statement in the publication was quite scary, but a good point to remember. Protective garments that cover the body from the area from below the chin to knee height provide shielding from the greatest amount of scatter radiation, including that which is present under the table. So that's why it's very important to have the right size and the right length of garment and the full body protection. What do we do with staff members who are pregnant? And I guess this differs from hospital to hospital and may differ from group to group, and it will depend on your own guidelines and your own regulations. In some cases, in some instances, there may be individuals who still need to work in a particular environment or a particular operating room where there is radiation, and it's not that they can avoid it, or perhaps they can't step out and they're still required to be at the table. Very important that the pregnant staff member notifies the radiation safety officer. The guideline goes on to say that we should follow standard radiation protection techniques, and in addition to that, it states that we should wear a maternity or a double thickness garment. That could be quite painful, I should imagine, or quite tiring when you're already pregnant to wear something that's even heavier to wear. The garment ideally should be a wraparound that's large enough to cover the entire abdomen. There's an image on the right from the guideline, from the journal, that shows you it looks like a vest and a skirt type version. In this guideline, they talk about wearing the dosimeter under the apron if you're pregnant at waist level, and wearing a second dosimeter in the center of the collar. Then, of course, reporting and monitoring the monthly dosimeter readings to make sure that you don't have a cumulative exposure amount that is excessive. It does in the guidelines specify what that amount is, so we can look at that, or if you need that information, please let me know. Radiation monitors, so of course dosimeters, which we all use, hopefully. Quite obviously, wear them if you're exposed to radiation or X-rays. Wear them in a consistent location on the body. Remember, this again is what it says in the guideline. I know sometimes in the South African context we only have one dosimeter, but they often speak of wearing two. And of course, depending on your circumstances, try and understand that you use the dosimeter to the best of your ability. Wear one on the outside of the body, closest to the radiation field when scrubbed. Wear one on the side of the body closest to the field. Sorry, wear one outside. If it's on the collar, one on the center collar if you're not scrubbed. It specifies where you should wear what. Label the dosimeter so you know where it is you're going to wear it. If you're wearing two, make sure you wear the same one in the same place. Always store them in a designated location, of course, quite safely. Don't remove them from the hospital at the end of the day because they could collect ionizing radiation from other sources like the sun, and hopefully you didn't go to the airport with your dosimeter on your shoulder or in your handbag. So very important that we manage this correctly because that information is there to protect you at the end of the day. It is really important that we know how much radiation exposure you've had. Moving on to the topic of brachytherapy. So brachytherapy being an example of radionuclides. Brachytherapy, of course, the implantation of some internal radiation therapy like a seed, a ribbon, or a capsule that contains a radiation source. We implant that somewhere near the tumor. In this section, they spoke briefly about minimizing the handling of sealed radioactive substances, limiting the number of people in the operating room to only those who are essential, the importance of accounting for all radioactive seeds that you don't lose one, posting a sign at the entrance of the door of the operating room to say radiation is in use. And that is, of course, applicable to all operating rooms and all areas where there's radiation being used. And then they refer to emergency response equipment specific to the type of radioactive seeds. I'm not 100% sure what that means. In some other articles we read, they spoke about having Geiger counters in case something goes missing and you need to be able to identify or find a seed in the operating room and you can't see it. Then perhaps a Geiger counter can help to identify where the seed is. Important information to know, and if something goes wrong, who you're going to call. Are you going to call somebody in the X-ray department? Who's your radiation safety officer? And that's why education is important. And I don't know if it's something that we do all the time on radiation safety. I should imagine that our radiographers know quite a lot, and those who supply us the garments may know quite a bit about radiation safety. And we should really and truly be encouraging that we host education sessions for our staff. In the April edition of the ARN, in each journal, by the way, there is always a monthly section called Clinical Issues, and it's a question and answer section. So people write in with their questions, and the staff from the ARN respond. And April happened to be all around radiation as well. Somebody posed the question over here, what are the recommendations for cleaning X-ray aprons and other radiation protection devices? You heard, of course, in the guideline already, they did say, remember to follow the manufacturer's instructions for use. In this particular article, they go on to remind us again that if the equipment is used by the same person throughout the day, you will clean it at the end of the day. But of course, if it's soiled during the procedure, you want to clean it immediately. If it's being used by different people, after each use, you need to clean and disinfect. In this article, they go on to talk about some research conducted on lead aprons, where they cultured 4 sites on the lead aprons. They cultured them just after cleaning and 6 hours later. So this was, they referred to an article that had been published in the Journal of Infection Prevention in 2019. The microorganisms cultured included Staphylococcus and Streptococcus viridans. I had recently also come across another article, again, also dealing with bacterial contamination on lead garments in the operating suite, in the same journal, mind you, but published by different authors in 2020. In this case, they stated in their guidelines or in their publication that 87% of the lead aprons, in fact, were contaminated. So it is a matter of cleaning as well as disinfecting, hence the term decontamination, not just clean. In their instance, they found that most commonly Staphylococcus epidermis was found on the lead aprons. So not only do we need to look after them, but we need to make sure we decontaminate them properly and carefully. Another question raised was, my facility stocks only extra large sizes of aprons and our wear is small. Should they provide my size? The answer from the ARN was around a published paper where they used a model, not a human, I think that's why they called it a quasi-experimental study. The model represented a female an orthopedic surgeon. They then exposed the model to radiation doses, wearing an apron that was too big, an apron that was too small, and an apron that was in the correct size for the model. And as you can see over there, the apron that was too large and the apron that was too small was not very effective, in that the dose of radiation received by the model was way higher than that of wearing the correct size. There's nowhere in the guideline that anybody specifies, or at least in this article, where they specifies what the correct size is, but hopefully those people supplying you with the safety garments can assist you with that. Nanette provided us some additional information over here about the South African context. And if you log on to the South African Bureau of Standards portal, you can see some information about radiation protection and radiation protection services that they offer. And then here's the link to the Department of Health's radiation control guidelines, code of practice for medical X-ray equipment. And if you need the link, please do feel free to send us an email and we can share that with you. Okay, so that covers our section on radiation safety. And now we're going to move on to looking at ergonomic challenges in the operating room, another important factor for us. This is an article published again this year in April 2021 in the Operating Room Journal. The title were Ergonomic Challenges in the Perioperative Setting. The little extract that I've posted on the top of this slide really caught me. Many perioperative nurses are required to stand for prolonged periods of time, placing them at risk for developing a variety of medical conditions and problems, of course, lower back and extremity pain and cardiovascular abnormalities. The abstract goes on to talk about perioperative personnel who are responsible for a variety of physical tasks, which include moving and positioning patients, holding extremities, moving equipment and supplies, and they talk about the fact that they have an aging workforce, which they do in America, and so do we in South Africa. To the best of my knowledge, our nurses as a whole are also an aging workforce. The physical demands of the perioperative environment can certainly affect the development of musculoskeletal disorders in our older nurses. This they talk to in terms of the Americans, saying that there's a lack of literature on the effects of the ergonomic risks on the perioperative nurse in the United States. They talked to the fact that in 2009, the AORN established a workplace safety task force, and they went to have a look at what can be defined as high-risk ergonomic tasks in the operating room setting. Initially, they spoke about transferring patients on and off the operating room table, repositioning a patient on the operating room table, lifting and holding patients' extremities, which of course we often do, standing for long periods of time, holding retractors for long periods of time. I hadn't actually thought of that originally. Lifting and carrying supplies and equipment, and pushing, pulling, and moving equipment around on wheels. Subsequently to that, they added a few more aspects, as discussed in this article, that things like wearing lead aprons, inadequate lighting can be an ergonomic risk, wet floors, using broken equipment. And then they've started to add concepts like cognitive risk factors and organizational risk factors. And cognitive risk factors, they refer to examples like lack of effective communication. Organizational risk factors, they talk about having to do overtime, where it's mandatory that you do overtime, or working when you're ill, for example, because there is nobody else to do your tasks. So also important things to talk about. So this article, they did a literature review of published papers in the language of English between the period of 2000 to 2020, with specific keywords that they looked at: ergonomics, musculoskeletal, nurses, perioperative, surgical team, and injury. And out of that, they came across a variety of papers, but not that many out of the USA, but out of Netherlands, Iran, Egypt, Israel, Sweden, Turkey, Germany, and Europe. The ones out of Turkey, we spoke quite a bit about those in our webinars we did last year. Some important points that I thought were quite interesting and made me take note in this particular article, talking about the fact that if you're lifting things, if it's a one-handed lift, the maximum we should be lifting is 5 kilograms. If it's a two-handed lift, the maximum thing we should be lifting is 10 kilograms. It also goes on to specify what pulling force for women should be, and that's a sustained pulling force. So if you think about it, if you are retracting a retractor when you're helping expose something during the surgery, or you are pulling or pushing a patient when you're moving them from one bed to the other, that it should not be more than 16 kilograms, and that is once per 30 minutes. If you think about a fast turnover list, you're doing D's and C's or some urology list, your patients are coming in and onto the table every 15, 20 minutes, and I'm sure that we exceed those guidelines. They also refer to the fact that muscle endurance decreases by 48% after 1 minute and 65% after 2 minutes. So if you think about it, if you're holding a limb, if you're busy cleaning a leg or an arm for prepping it for surgery, it can become a very, very heavy item. So please take that into cognizance. Another important, interesting fact was that the patient's head and neck weighs 8.4% of their body mass. So the individual holding the head might be okay in terms of the amount of weight that they can lift, depending, of course, on how heavy the patient is. But then how many people are left to move the rest of the patient's body weight? And is that within the 16 kilograms? Sadly, in the article, they say that very few of the studies include any interventional measures. There was one that referred to staff participating in a fitness program. I tried to visualize a whole bunch of nurses in the perhaps in the recovery room. Maybe that's where the biggest space is at 7 o'clock in the morning, doing a bit of a morning workout. But perhaps that would be worth it. Perhaps we can get a biokineticist in to help us all first thing in the morning before we start our heavy workload. They also go on to talk about the fact that occupational injuries in the healthcare setting are grossly underreported, and that persons with a BMI of greater than 30 had a higher rate of workplace injury. What are the solutions? There are a couple of solutions mentioned in this particular document. They also, though, refer to, in the article that is, and they also refer to other ARN guidelines that seem to have more solutions listed in them. What I could get out of the article was, firstly, that nurses and perioperative staff need to be proactive. It seemed to say, please make sure you look after yourself. Make sure you request assistance when lifting heavy loads. I think we do that sometimes, but often most nurses get frustrated or irritated and can't wait anymore and go along and do it all themselves. That's what we do tend to do. But of course, we might regret that decision because we could hurt ourselves. They speak to the fact that we should report any ergonomic concerns, I guess, to the management. and the importance of trying to make use of the correct equipment to reduce the workload. They speak of anti-fatigue mats. I've not ever had any experience with an anti-fatigue mat. I don't know if anybody's ever tried them. And then I thought about the fact, what about talking to your theatre table supplier around the accessories? And I'll show you an example of that now. What's the role of management? Conduct an ergonomic assessment, a very important concept. Have a quality improvement program in place. I'm currently working on a course for all of us, a refresher course in the operating room, looking at quality improvement programs and what it is what risks we have and what quality improvement programs we can perhaps put in place. So hopefully teaching us all and teaching our theatre nurses to learn to take responsibility in their own operating room for themselves and what they can do in that given setting, and don't only rely on the theatre matron to come up with everything for you. It is also, of course, the management's job or responsibility to help to budget, to purchase the right type of equipment and hopefully keep you safe as a result. Here's an example of a piece of equipment that could possibly be helpful. So removing the bottom end of an operating theatre table, so either if it's split legs or if it's a single leg that's quite heavy, and then replacing it with a much lighter support that is safe for the patient, but much lighter when you have to remove it all the time in and out, especially when you're putting patients up into the lithotomy position. Although our session has now been about 30 minutes long, 35 minutes long, we've had a lot of detailed information to talk about. We've reminded ourselves of the potential side effects of exposure to radiation, the horrible, dangerous side effects. We've reminded ourselves of the importance to wear all of our radiation safety garments. We've spoken about the Alara Principle, using a radiation dose that's as low as reasonably achievable, keeping our distance, reducing the time, trying to minimize the dose, wearing our equipment properly, protecting the patient, protecting the perioperative team, where to put the X-ray image intensifier, how to keep yourself safe. We've spoken about the fact that our lead aprons are in fact contaminated, and we need to be cautious around that, and we need to decontaminate them properly. And then we've spoken about the challenges in the operating room for all of our ergonomic challenges, and we focused really on the physical stuff and perhaps a few solutions around those ergonomics. Hopefully you found today's session interesting. Next week we will have a bit more of a CSSD focus. The week thereafter will be again a theatre focus. We'll take a bit of a break for a while after that. We'll probably come back with some sterility assurance webinar series and continue with these Insight webinars 2021 again later on in the year.